Hello, folks. This is your host, Dr. Graham Taylor. Before we begin today's episode, we have a special announcement. Please come join us for the 2024 Triad Summit Series. Mark your calendars for May 17th from 9 a.m. to 11:30 a.m. Pacific Time. This event is online and is completely free to attend. At this one-day summit, you'll have the opportunity to learn from two esteemed experts as they share valuable strategies for addressing the mental health crises that we are in, aiding in trauma recovery, stress management, and helping individuals reach their highest potential. Don't miss this chance to connect with innovators in mental health, gaining insights from industry leaders, and fostering connections within the wider wellness community. Learn more and reserve your spot today at triadhq.com/TSS. That's triadhq.com/TSS. I hope to see you at the summit.
Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective. Welcome to Behavioral Health Today, a Triad production. I'm the producer, Peter Fanger, and I have the pleasure of welcoming you into today's episode. In our show, we'll resume our conversation with our host, Dr. Graham Taylor, and his guest, Dr. Lloyd Sederer, in his book, Caught in the Crosshairs of American Healthcare. In our last episode, we discussed the detrimental effects of corporate influence on patient care, including decreased quality of care, physician burnout, and moral injury, the importance of human connections and supportive relationships in the healthcare settings, and the challenges facing the American healthcare system. We'll resume our talk today by discussing the negative impact of financial control on medical and clinical decisions and how corporate ownership in healthcare often prioritizes profit over patient care.
Lord, I want to park a little bit more and have you emphasize the importance of really understanding the impact of McLean's history and the significance of understanding this in terms of how it can happen, if it can happen with them, how it can happen in other places too. So please kind of park on that a little bit for us and expand upon this experience, would you?
Please, thank you. And I would like to start by just reading a couple paragraphs from my book on the subject, Caught in the Crosshairs of American Healthcare. McLean became a very desirable target for the fast-growing corporate control over U.S. healthcare. It not only represented traditional medicine, where doctors make decisions rather than corporate decisions, it was also about being such a iconic hospital, having the kind of stature. So taking down McLean by for-profit corporate businesses could be seen as shooting a prize elephant in the herd. And McLean, our unwillingness to bend to the financial and clinical demands of for-profit health insurance companies and their tentacles, the managed care companies, made McLean a place even more of a trophy worth winning.
Wow. What's the significance of taking down the prized elephant? Why take down the trophy elephant?
Well, others had already been shot and taken over, but this was another hurdle. This was a Harvard teaching hospital. This was where famous people went. This was where the families of very prominent people went. This is where prominent celebrities. So it had its own aura, different from a very good private hospital. This was a not-for-profit. So it had that iconic reputation. And when you're out to take over a whole industry, it does help to shoot the prize elephant.
So they get bragging rights. We could say it that way. They get bragging rights. But what is the benefit to them other than owning the whole herd or having shot the whole herd and being in control of this? Is that it? Just the financial control?
In effect, the financial control creates the medical clinical control,
right?
Because decisions are not made by doctors, nurses, health professionals. Decisions are made by often on a 1-800 line, and now
Yeah.
AI-driven decisions. So McLean stood to be an example that we were not going to go that route. It wasn't just the financial, because we didn't want to serve people in the way that the corporations insisted, the managed care companies insisted, which was mostly to limit what people could do, was what clinicians could do, to drive payment down to such a level that you had to, get to core business activities and not to the other things that may enhance psychosocial aspects of care, aftercare, involvement of the family. All of these are necessary, I think, for good quality care, and you can't do them at $600 a day.
Yeah. Lloyd, I think this might be one of the handful of best takeaways from this podcast is that the medical clinical decisions are not being made by those that are best in position and training with expertise to make them. And you're saying then it shifts. It's not the docs like it was with McLean, where there was great results. There were good outcomes. People were having their lives changed. And it shifts to people that are making decisions that are simply the bean counters. It's a financially driven set of decisions. Who are typically, have you learned, who are typically the folks making these decisions now at a corporate level?
Simply moving to artificial intelligence,
Yeah.
where essentially you call or you type in and respond to a set of key questions.
Yeah.
Was the patient suicidal yesterday? Did the patient shoot somebody, or did the patient run away? If you don't get the right answer for all of them, you'll get denied or delayed.
That's
And
right.
it's virtually impossible. I think these programs, this is a little bit of a conspiracy theory, but I think these AI programs by managed care in mental health are written by the same programmers that write programs for casinos, because the house always wins, and the house is
Yes.
house of medicine.
Well, just a note around that, we know that the formularies and the programs for AI, I mean, ideally, if you look at AI and say, well, AI has this ability to take a look at everything ever written, every program ever created, and take the best parts of that, synthesize it down, and provide you with the very best response. That could have some real merit. It's the smartest person in the room all at one time, but we know that AI can be programmed. We know that it can have certain filters and things along those lines. We already see it happening. So you're right. It's like the house is always going to win by those who are programming the program just the way they want it to have for the outcomes. I would love to hold this one where the corporate control is really what's shifting here, in the sad reality of McLean being such a stellar kind of light on the hill program that could have been replicated and modeled and showing good care. Let me just hold this one for right now. Read me another excerpt, would you, from your book? I'd love to hear something else that you've written around this. I'd love to hear it.
Well, this is what I call the field work,
Mm,
because when I got the job, I realized I had to change the culture of McLean, of the professional staff, particularly the senior professional staff, because the place was dated and it needed
mm.
a modern model of psychiatric care. And I happen to know a bit about it. I written a textbook and done it at other hospitals, Mass
I know
General.
you had.
And so on my calendar right away was to go and meet with many of these senior psychiatrists and psychologists. And this is a story of one of those appointments. Upon my arrival, I knew I had to make the rounds to visit the senior doctors by appointment in their office, not mine. I appreciated that some had been passed over and soon would no longer have their posh practices and Harvard medical appointments. None of them was going to abide with the mission that we had already determined to radically change McLean in order to keep it going in a clinically significant, and in order to make McLean a beacon of what really good care should be, really good psychiatric care should be. So my aim was not to win them over. That would have been naive and wasteful of precious time. But I knew it could be painful and disorienting to be out in the professional cold after the very protected haven of McLean Hospital. And I knew that personally. I went to see one senior psychiatrist who no longer was a candidate for leading a clinical program. He sat in his rather empty, big desk, squarely facing me. He said, I would be out of McLean in disgrace, in short order, too. I said nothing in response. It was a brief meeting. It was the tone of many people who saw a movement towards away from long-term inpatient care, away from long-term psychoanalytically oriented psychotherapy for very ill people in acute illness, schizophrenia, bipolar, was in their hearts, they still held onto the conviction that what they were doing was right. It was the best way to treat people. Mm-hmm. And it no longer was, but I don't think they were giving me or others a hard time. It's what they had been doing for a long time and that they believed in with utter conviction.
We'll be right back after word from our sponsor.
Are you preparing for a licensure exam in psychology, social work, marriage and family therapy, counseling, or behavioral analysis? AATBS is here to help. We have been supporting behavioral and mental health students to prepare for their licensure exams for more than 45 years, working with over 1 million students to succeed on test day and move on to the next step in their career. With products ranging from comprehensive courses to quiz banks and delivered live online, self-study online, and in print, AATBS has test prep solutions that meet every student's needs and learning styles. Visit us today at aatbs.com. That's aatbs.com and use promo code BHT15 to save 15% off your next purchase.
Yeah, it sounds like they did. I love these excerpts from your book, and they are highlighting the trends that are happening more and more in our nation around care being given in the best practices kinds of ways versus the corporate control that can happen. Can we segue just a wee bit to this concept of what are some of the solutions here? You've been around for a very long time. You have a phenomenal history, written books, presentations, in charge of, the New York healthcare. You are the man for having this institutional knowledge. Truly, I'm not blowing sunshine your way. This is true. Where you have this institutional knowledge with this 10,000 foot view, maybe even a 40,000 foot view that says, what can we do as some solutions? And what are some of the things that we need to consider as the healthcare system continues to evolve? What's going to be important for us in a solution focused way?
Yes. So I have zeroed in on what I think are 3 solutions. They're not very comfortable or easy, but it does narrow the path of how to resist, how to successfully overcome the control of decisions by corporate programs.
Yes.
So the first is patients and families.
Mm-hmm.
And what I mean by that is that me, you, all of us need to become what I consider what's called a demanding patient. We used to call these difficult patients.
Right.
We are owed as patients a doctor looking at us, a doctor explaining what he or she thinks is going on and why they chose the treatments that they have and what are the side effects and what can they expect. That's owed to a patient. And that's not what's going on hardly at all. So it is about a grassroots revolution in a way about what does a patient need to do? What does a family need to do to ensure that they or their loved one is getting proper care?
Yes.
And mostly people are intimidated by doctors and hospitals, and they go in and, they're quiet or passive. And that's not what we need now. We need everybody to come in and say, hey, wait a minute, you didn't answer this question, you didn't answer that question, because that then begins to upset the apple cart.
Yes. You know what's interesting about that is that there is in a perceived power differential between doctors and patients. And there's really not. What there is an expertise differential, and that's fine. That's why we're going to the doc the same way I would go to an auto mechanic. But there's not a power differential there. He just told me what's wrong with my car. And then collaboratively, we work as to what's the best way to fix it. Ideally, I think most docs, if they step aside from the pressures of the managed care, want a relationship with a patient that says, hey, can we talk about my options? Can we collaborate here together so the doc doesn't have to have all the pressure of that godlike decision-making process, but the opportunity to say, hey, here's what some of the best practices are. Here's some options for us. Let's talk about the pros and cons of each one, and maybe collaboratively together, we can make this shared decision based on the information that we have together. I think most docs would appreciate that kind of relationship more than the perceived, okay, what do I need to do, and just follow it.
Well, you know this personally as a doctor, as a clinician, that the heart of the encounter is the doctor-patient relationship.
There you go. Thank you for naming that piece.
About creating a bond, trust
Yes.
between the doctor and the patient. The trust is created by essentially having that person's needs primary, foremost. And you do that in the way that you describe by expertise. That's how you develop a good doctor. And that's very rewarding to us who are clinicians, because that's why we went into the field to begin with.
That's right. That's exactly right. And now we get an opportunity to manifest that and express that. Give me the second solution. You said you had
Second
three.
solution are professionals. And I'll just highlight doctors, because there are others, important nurses, but physicians, psychiatrists, doctor-level psychologists. They have two tools that they can use in response to this corporatization. The first is contracts. And more, these large insurance companies and managed care companies form a contract with not a single person, but a group of doctors or a hospital.
Mhm.
And one example of can't take it anymore happened in Southern California not so long ago. And one very large doctor group, not just psych, but all specialties, had a huge contract with Medicare to take care of, countless subscribers, 30,000
Mm.
subscribers. And their contract was up for renewal. And sure, the insurance companies thought, well, it's just another day. They did not renew the contract.
Huh.
And overnight, 30,000 subscribers, which is how they're seen in the corporate world, were without a doctor or doctor's office to go to.
Amazing.
That is extremely disruptive. And we're not going to get anywhere with little meek activities. We're going to get there by forcibly taking back control, by saying, hey, wait a minute, we're not going to do that. Here's what we're going to do, and here's what's necessary for us to sign another contract with you. So that's contracts. The second aspect of this, and here's where I could also get into a lot of trouble, is unions.
Yes.
Doctor unions. And the reason for that is because unions can strike.
Mm.
They can have their members, their doctors, not go to work,
Yes.
which is as disruptive as not renewing a contract, because then the hospital and the payer is caught in this situation where the doctors are unified and the doctors have a point of view, and you've got to negotiate with that or they're going to go on strike. So
Yes.
striking is a very powerful weapon, and nurses have known this for a long
Yes.
time, but physicians, doctoral psychologists, others in these big specialty groups have hardly done that.
I don't think I've ever heard of a group of docs striking. We just had one here for a local hospital. They struck, and we had another one. Nurses striked here as well, twice in the last couple of years. And it is a powerful message that gets across. People listen. Services are disrupted. Money is not made. And you're right. There's a very, very powerful stance that can be taken.
When there's no revenue if
Right.
you're out there seeing patients. And
Yeah.
revenue is the foremost goal of these for-profits, to make a profit. And you can't do that if your clinicians are not going to work. So these
Yes.
two tools, contract and unionization, are very powerful ways, and I think they're inescapable, and I think they're starting to happen. There was some, I think, resident union, in Cambridge, Mass, and there
Mhm.
are some others that are beginning to emerge. And unions are on the rebound. Unions had essentially almost gone away in recent decades, but now they're on a path where professionals and others need them in
Yes.
order to maintain their integrity.
Yeah, outstanding. So we have become a demanding patient, really look to cultivate that relationship with a doc. And then you got contracts and unions. Give me the third one in terms of solutions and kind of some next steps.
The third one is judicial. And I don't mean federal government. I don't mean Congress, which is, hopelessly tied up. But I'll give an example, because what can be done, it can be done by what's called a special master.
Hmm.
And a special master is appointed by the courts. And after 9/11, there were more than 10,000 people who went to sue other companies or needed money in order to pay for their lung disease that the collapse of the buildings had caused. And a special master was created
Hmm.
at that time. I think it was a year or so later, appointed by the courts. And that person has absolute authority over what goes on.
Wow.
And in this instance, it was to protect those people who had suffered the consequences of the bombing, and also the view that, oh, just go to work, it's not going to be a problem. And that special master still exists. And over $11 billion has been paid out from the 9/11 fund to about 10,000 people. And it's been a succession of masters. And the last master was appointed in 2023 by the Attorney General. And so that person continues a line of people who are in need as their primary determinant, not profit.
That's how I never knew about that, Lloyd. So the special master is making these decisions in some unilateral ways, but with the best interest of the patient. Are they telling the insurance companies that they must provide certain services or certain fundings towards things? Is that what they're
Well,
influencing?
it depends on what the services or the
Yeah,
monies control. In the
got it.
case of 9/11, it was insisting that people who had proven consequences got settlements rather than just being, run around the bush or dismissed. And the whole flow of the settlements had to pass through the special master. And the
Interesting.
filter that they had was, is this what this money is for? Is this what this service is for? It's
Yes.
not to try to, protect payers and others who may have benefited by not providing services or money to help for these people to live. They were there to protect those people who had been impacted by a disaster. This has happened also in some correctional facilities. And I have not seen one in mental health yet. And as you said, I have a pretty broad view, but I have not seen one. And I don't understand. Maybe it's just a political constipation that exists here, because Congress could call for a special master send it through the Attorney General's office. It's judicial decision. They could do that, and so many people are unhappy with what's going on that power of a special master is in the hands of the judiciary.
Yeah, that's really good. These are great. I mean, you're kind of taking us outside the box that we get ourselves stuck in. We become rather myopic over time, just thinking, well, this is the only way that it has to be, or this is the way that it must be. And what you're doing, you're kind of opening this aperture for us to see that there are ways to resolve this. There are ways to address this and change this path that we're going down here. Your book, Caught in the Crosshairs of American Healthcare. What impact would you like it to have, and how do you see the things you're sharing in it ideally having the greatest influence about decisions being made in the upcoming years regarding our healthcare here in the United States?
I hope that it serves as a positive example, as a story, because it is in the form of a story. Some
Yes.
reviewers said it reads like a novel, or it's
Yeah.
just, but the story is that you can win. It's going to be hard. Here's what you're going to face. But if you do that, you will win. And I like to use the Gandhi quote here, famous quote by Gandhi, which is about radical change. First, they ignore you. Then they shame you.
Yeah.
Then they fight you. Then you win.
Mm.
That's not an overnight process, but the book served as an example, heartening example in my life and further jobs, that this can be done. But boy, you have to have the grit and the patience and the support of those people who are in authority, and you, for example, your board especially, to
Yeah.
do what's needed.
Really good. We're kind of winding down here in our show today, but I'd like you to leave a message, if you would, to kind of the power that the average person has at their own personal grassroots level, if you will, in this process, maybe even with their own physician. Remind us of the power that we have. Power
It-
for good, power
that-
for change, power for kind of beginning to shift a mindset. Would you leave us with a word around that?
Yes, it circles back to being the demanding patient. It's not that you're difficult. You're owed this information. You're owed this collaboration because it's your life, it's your body, it's your health.
That's right.
People in general need
Yeah.
to recognize that that's where what we individually can do.
Yeah.
Anything larger than that, contracts or judicial, that's out of the hands of individual people. And if an individual person goes to war with an insurance company, they're going to be obliterated or ignored. So it is about what control individuals have, and that control is at the level of their care and what they are honestly do.
I think the reminder that no one is going to care about us the same way that we are going to care about ourselves. It's not that doctors don't, have a certain fondness for us or care for us, but they're seeing multiple people a day. And after they're done with that day, they're going to go on to the next day. And we like to think that, almost like a good parent, they're going to be keeping us in mind and thinking about us and having reminders in the middle of the night to call us. And that's not going to happen. So to be able to be that demanding patient, not someone who's, irascible and hard to deal with. It's not a difficult patient, but it's the demanding patient for the right kind of care that everyone deserves, I think, is a great reminder.
Yes,
And I think
being
that's where things begin to
demanding
change.
doesn't prevent you from being respectful.
That's right.
This is
That's
best
right.
done in a respectful manner.
That's right. You and I are going to what comes to mind real quick. You and I are going to come back on a future show and talk about masculinity. And all masculinity has toxicity attached to it. No, it doesn't. There's toxic masculinity. There's masculinity that's necessary. Same thing with femininity. There's femininity and there's toxic femininity. What we're talking about here is you can be a demanding patient without being disruptive in a negative way that's going to have consequences. You can be demanding, kind of almost a righteous demanding, where there's a righteous indignation and a righteous request for things that are right that begin to change. So this is such an important area. And, Lloyd, as we wind down, I would love our listeners to be able to follow up with you after today's show about you and your new book, Caught in the Crosshairs of America, and all the work you've done. Give us some links to that, would you?
Well, I think the best way to reach me and the way people do is to go to my website. And it's very simple. It's one word, Ask Dr. Lloyd, AskDrLLoyd.com. That's my website. And you'll see there a bunch of tabs, things that may be relevant to you, whether they're books or talks or information about some condition or another. And you can select what you want to look at. And you can also send me a message through that,
Nice.
because there's a tab there that says, would you like to send a message? And I get messages and I respond to them when they're particularly specific, like, oh, my son is on this medicine and this dose and that dose. I can't respond because that's practicing medicine without essentially seeing the person and caring for the person. But in many other ways, this is an opportunity to talk about what good care is, how it's rendered, and how do you know you're in the right place when you're seeking care and when you're not, you got to get the hell out of that office.
That's right. Really good. Well, Lloyd, my friend, you are a true treasure to our profession. I kind of think of you as kind of America's psychiatrist. And I mean that sincerely. And I appreciate and thank you for the ongoing impact that you continue to make in our field. In this season of your life, you're into shaping, I think, some things, and with your experience, with your credibility, and with your influence, and just with your heart. I think the impact you make and the lives you touch is very, very significant. And I always love having you on the show. I look forward to having you back. But for today, thanks so much for being with us.
Thank you. It's always a privilege to be on your program.
I appreciate that. Well, I also want to thank you, our listeners, for dropping by and joining Lloyd and me today. It's always great to have you with us as well. I've also got some exciting news for you. I'd like to invite you to join us on a 2-day 16 APA CE online live practitioner training in self-meaning-based therapy this month, May 18th and 19th. Self-meaning-based therapy is an approach that's been referred to as groundbreaking, transformative, innovative, and pioneering with great integrative reach. Learn how to help your patients uncover and transform their unconscious core negative self-meaning, which lies at the heart of psychological suffering. Rather than simply managing unconscious negative effects of self-meaning with best practice approaches, therapists can now help patients permanently dismantle it and help them realize psychological freedom from the self-created lie born during childhood. Self-meaning-based therapy also allows patients to reconnect with their inherently creative and natural design and experience their true self. You can sign up for this course at www.wellness-institute.org/self-meaning. Regarding our episode, I want to remind you that it and its resources and all of our other episodes can be found on our webpage at triadhq.com/BHT. Thanks again for being with us on the show. And we'll look forward to having you back with us next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Network, all rights reserved.